This recording will go over part 2 of spinal cord injury. For gastrointestinal and genitourinary assessment, we want to assess the patient's abdomen for symptoms of internal bleeding, such as abdominal distension, pain, or paralytic ileus. Monitor for abdominal pain and changes in bowel sounds. Paralytic ileus may develop within 72 hours of hospital admission. During the period of spinal shock, peristalsis decreases, leading to a loss of bowel sounds and to gastric distension. Patients with cervical or high thoracic spinal cord injuries have upper motor neuron damage that spares lower spinal reflexes and causes spastic bowel and bladder. Patients with lower thoracic and lumbosacral injuries usually have damage to their lower spinal nerves and therefore have flaccid bowel and bladder. Long-term complications for a patient with mobility issues shouldn't be new to you. Most students off the top of their head are watching for skin breakdown and are also worried about clotting, VTEs, or DVT. One complication students often forget about is osteopenia or osteoporosis. So if a patient does not have normal mobility, we're worried about those bones weakening as well as fractures. Bones become more weak because part of what keeps bones strong is weight-bearing activities. And if I've had a spinal cord injury, I'm no longer walking, I'm not bearing weight, that's going to lead to weakening of the bones. A new term for you might be heterotopic ossification, or HO. It's a bony overgrowth often into muscles. You want to look for swelling, redness, warmth, and decreased range of motion of the involved extremity, and the hip is the most common place where HO occurs. For psychosocial assessment, patients experiencing a spinal cord injury may have significant behavioral and emotional reactions as a result of changes in functional ability, body image, role performance, and self-concept. For labs and imaging, a big one would be a spinal CT, as well as an MRI that would be performed to determine the degree and extent of damage to the spinal cord and detect the presence of blood and bone within the spinal column. In addition, the patient may have a series of x-rays of the spine to identify fractures or any other problems with dislocation or any other bone issues that might be going on. In terms of priority problems, what are we worried about for the patient? Respiratory distress and failure, cardiovascular instability, the potential for secondary spinal cord injury, and decreased mobility and sensation. In addition, the patient with a long-term spinal cord injury is at risk for multiple problems caused by prolonged immobility and impaired mobility. Airway management is the priority for a patient with a cervical spinal cord injury. Patients with injuries at or above T6 are especially at risk for respiratory distress and pulmonary embolus during the first 5 days after injury. These complications are caused by impaired functioning of the intercostal muscles and disruption in the innervation to the diaphragm. Depending on the level of injury, intubation or tracheotomy with mechanical ventilation may be needed. Heavy respiratory focus, obviously, especially if it's a cervical level spinal cord injury. So I want to be assessing breath sounds regularly, listening for adventitious or abnormal lung sounds, diminished lung sounds, watching for changes in respiratory pattern or any type of airway obstruction. Respiratory secretions are managed with manually assisted coughing, pulmonary hygiene, and suctioning as needed. Implement strategies to prevent ventilator-associated pneumonia. Pulmonary hygiene, remember those are things that keep the lungs clean, so instead of spirometer, deep breathing, coughing, all those things. We want to make sure we're doing frequent respiratory assessments. We can perform oral or nasal suctioning as needed. If the patient is a quadriplegic, we can teach them to coordinate cough efforts with an assistant known as a cough assist, kind of similar to the Heimlich maneuver, but in this case, the assistant is putting extra pressure on the diaphragm when the patient coughs, just to give that cough a little extra boost and make it more productive. Next up, monitoring for cardiovascular instability. We want to maintain adequate hydration through IV therapy and oral fluids as appropriate, and we want to carefully watch for manifestations of neurogenic shock. Remember, that's our shock where we have low BP, not enough to perfuse our organs, anaerobic metabolism going on there. Things that can be used for a patient experiencing shock. Dextran is a plasma expander. Can be used to increase capillary blood flow within the spinal cord and prevent or treat hypotension. Atropine is a medication you should have down by now. Atropine causes one thing to go up and one thing to go down, right? The one thing in atropine that goes up is heart rate. It's used to treat bradycardia. So if the patient has bradycardia, we can use atropine to bring up that heart rate. Side note, the thing that it decreases is secretions, commonly used before surgeries. Hypotension, if it's severe, can be treated with IV sympathomimetics. Sympathomimetics mimic the sympathetic nervous system. So they're going to be mimicking or causing a fight or flight response within the body. They include phenylephrine, dopamine, and other vasoactive agents. For the patient who is at risk for neurogenic shock, patient after spinal cord injury, we want to monitor frequently their blood pressure, make sure the systolic stays above 90 or their MAP above 65. Also check their temperature, checking for any temperature dysregulation, and monitoring for symptomatic bradycardia. Symptoms including reduced level of consciousness, decreased urinary output are things we're going to be watching for. Autonomic dysreflexia is a neurologic emergency and must be treated promptly to prevent a hypertensive stroke. So if you remember, the big, most concerning symptom we get from autonomic dysreflexia is an extremely elevated high blood pressure. That high blood pressure can cause that sudden pounding headache. What we're worried about is that the patient then has a stroke because of the excess pressure in their head. So within your textbook, you got a box that talks about what are we going to do for the patient with autonomic dysreflexia. The first thing we do, you need to know this, is we raise the head of the bed or put them into a seated position, getting the head up. And what's the reason for that? If our problem is too high a blood pressure, we're worried about a stroke, so we're worried about something going wrong in the brain. By elevating the head, we let gravity help keep the pressure down a little bit in the head. So the first thing we have to do is elevate the head of the bed or get the patient in a seated position. Second thing we do then is figure out what could be causing that autonomic dysreflexia. If you remember, it had that long, odd description, condition in which noxious visceral or cutaneous stimuli cause a sudden, massive, uninhibited reflex sympathetic discharge. So something's annoying them either internally or externally, and we need to figure out what it is. A lot of times it's related to urinary system, so check for urinary retention, catheter blockage. If they have a catheter, is the tubing kinked at all? Is there any obstruction? If they don't have a catheter, check for bladder distension. Catheterize them immediately. So if they're just not voiding properly and they're retaining too much urine, we could catheterize them to relieve that distension. Consider UTI, kidney stones. Check the patient for fecal impaction, any other sort of bowel issues that might be going on. Look at the skin, see if there's any pressure points or anything getting pinched. Monitor the blood pressure frequently. And the provider can prescribe medication to lower the blood pressure as needed, but the goal would be to figure out what's going wrong and eliminate whatever that obnoxious stimuli is. Next up, prevent secondary spinal cord injury. So I've already fallen off my ladder, had my spinal cord injury. Now we want to make sure that my spinal cord's being taken care of and it doesn't get injured even more. So during the immediate care of a patient with a suspected or confirmed cervical spinal cord injury, a hard cervical collar is put in place to stabilize the spine until it's determined that the cervical spine is not at all injured. Until spinal column is stabilized, use jaw thrust maneuvers over a head tilt maneuver to open up the airway. That would be preferred. Maintain spinal alignment at all time. So your textbook talks about log rolling to change the position from supine to side laying. So basically log rolling is if you have to move your patient at all, you keep that vertebrae in alignment and you move the patient as one unit. So you're going to need assistance with that. The shoulders, the hips, the legs, everything's going to move at the same time. So I wouldn't, try to get the patient's torso on their side and then come down and try and move their hips. Everything has to stay in alignment. That would be considered log rolling. Let's see. The patient may have a fracture immobilized either with external fixation or orthotic devices to try and keep things from moving. They might have a spinal fusion. They might have metal wiring, bone grafting, rods implanted. After a surgical spinal fusion, we want to assess, so any sort of spinal procedure, right? What's our priority? Neural status. So assess neural status and vitals frequently. Look for complications, especially any changes or worsening of motor or sensory function at or above the site of surgery. So be sure to document your assessments very carefully and be very detailed. Failure to do so may prevent other staff members from quickly recognizing that your patient's neural status is declining. The patient may be placed in a fixed skeletal traction to maintain vertebral alignment, facilitate bone healing, and prevent further injury, often after surgical stabilization. The most commonly used device is a halo fixator device, which is worn for up to 12 weeks. It's fixed by 4 pins into the outer aspect of the skull and is connected to a vest or jacket. There's some key things to remember if you are caring for a patient or teaching points for a patient with a halo fixator. You never want to move or turn the patient by holding on to the halo device. We are not in charge of adjusting screws. We want to assess the patient's skin frequently. We want to make sure one finger can be inserted easily between the jacket and the patient's skin. Assess neural signs, and the patient should also have a special wrench available, maybe taped to the vest, so that they would be able to loosen the vest, or maybe not even them. Someone would be able to loosen the vest if necessary, if the patient was in an emergency, needed CPR, and we needed to get to their chest. Don't use sharp objects for scratching. Common complications are pin loosening, local infection, and scarring. More serious but less common complication includes osteomyelitis or cranial bone infection, abscess instability. We want to follow policy for pin site care and always be monitoring the patient for signs of infection, fever, purulent drainage from the pin sites, and make sure that the patient understands to be watching for those and report them as necessary. For thoracic or lumbar fusions, metal or steel rods are used to keep the bone ends in alignment after fracture reduction. Because spinal cord injury is a physical trauma, the patient may be prescribed a proton pump inhibitor such as pantoprazole to help prevent any ulcers. Calcium and bisphosphonates may be ordered to prevent osteoporosis that can occur because of lack of weight-bearing activities. Central acting skeletal muscle relaxants could be used to treat muscle spasticity, including intrathecal baclofen. We talked about that before. Intrathecal baclofen, they have a pump that deposits the medication into the cerebrospinal fluid itself. We want to make sure that there's no sudden withdrawal of intrathecal baclofen because it can result in seizures and hallucinations. The final bit of the chapter talks about managing decreased mobility, so how to prevent injuries such as pressure ulcers, clots, contractures, orthostatic hypertension, fractures related to osteoporosis. Those should all be reviewed for you, so I'm going to let you review those topics on your own.